Assalamu alaikum. I'd like to welcome Dr. Fawaz Alrefai for the second lecture. Fawaz Alrefai is the head of pediatric department at Dan Hospital, consultant pediatric gastroenterologist, and program director of pediatric respiratory residence program.
Thank you very much, Dr. Mariam, for the kind introduction. Again, I would like to thank the organizer for the kind invitation, on the top, Dr. Fahd Al-Anizi, for the trust. It's always good, to talk about constipation. We never get bored when we talk about this, because it's a common problem that you face as general pediatrician and we face as a gastroenterologist. It's a very common issue for us. So, chronic constipation is always a challenging problem, and believe it or not, it has a lot of negative consequences on family structure. So the outline of my talk, I try to keep this simple and to the point, and try to give you some practical tips on how to handle this problem in your clinic. So I will just give you an overview about definition, epidemiology, etiology, treatment, prognosis, and hopefully we'll have some recommendations at the end. So if you look at the definition of chronic constipation according to the latest, that was in Rome 3 criteria in 2006, there will be a Rome 4 criteria coming out this April. There will be no major change from this. So you need 2 or more of the following criteria: 2 or fewer defecation in the toilet per week, at least 1 episode of fecal incontinence per week, history of retentive posturing or excessive volitional stool retention, history of painful hard bowel movements, and a presence of large fecal mass in the rectum, or history of large diameter stool that can obstruct the toilet. Emphasis is changing, so we more focus on the functional definition of constipation rather than numbers. We have to take number into account, but doesn't mean everything. So we have to take more information about the size of the stool, shape of the stool, how is the child is doing when he or she is passing the bowel motion. And this diagram illustrates to you the normal frequency of bowel movements per week by age. And as you can see, going from left to right, when you are a baby, you have exaggerated gastrocolic reflux, and you are allowed to have more frequent stools. This is very physiological phenomena. When you grow up, usually by the age of 3 and above, your stool pattern will be much more like adults. And again, we have to ask, a family about if there is any family history of constipation, especially in the mothers, because, constipation can happen in families, and, motility has a lot to do with this as well. I always ask the parents whether anybody in the family have constipation, brother, sister, parents, because there is a familial pattern sometimes that we can see. If you want to look at the epidemiology, it varies depending on definition, because definition varies from one protocol to another. Overall, it's a huge problem. Probably 10 to 15% of children at least suffer from chronic constipation with different ages. It can present up to 3% of general pediatrician office visits, or up to 1/4 of our patients. This number can be increased in our clinic in Adan Hospital. We see probably 30% of our visits, somehow they came with the problem of chronic constipation. And usually parents are afraid of something wrong or dangerous. They always ask us to do more investigation. Do we have to do ultrasound? Do we have to do colonoscopy? Because this perception is very common in adult gastroenterologists, because they always worried about tumor, cancer, and so on. So sometimes because constipation can be an alarming sign in adults, but for children, usually we are not so aggressive because the pathophysiology is different, and majority of constipation in children is functional and not organic in etiology. So the constipation correlates with low maternal education, female gender, living in large community, and having no older siblings. This has been shown in some epidemiological studies. If you have exclusively breastfed babies, they are allowed also to have constipation. Infrequent bowel movements in young infants fed exclusive breast milk can be a harmless phenomenon that can easily be diagnosed by history and careful physical exam. So the bottom line, yes, if you are breastfed, you are more allowed to have more frequent bowel movements, but there are odd situations when we have children who are exclusively breastfed and they have a bowel motion every 2-3 days, sometimes once a week. If they are growing well and they don't have any problem, that's good and well. You don't need to interfere. If you want to look at the pathophysiology of encopresis, we have to understand what happened in normal phenomena. So on the graph on the left is just a diagram illustrating to you the colon, the rectum, the stool bolus coming down, and the stool bolus coming down, and once it goes down in the rectum, it causes distension of the rectum, stimulation of the pressure receptor there, relaxation of internal sphincter, and then evacuation of stools. What happened in children with chronic constipation, and this is always a lesson that I emphasize on when we face parents, we have to make them understand what happened in children with functional constipation. So the stool bolus come down, stretch the rectum, and the child disinhibit or prevent this reflex from happening by ignoring the signals that coming to the muscles to relax. And with time, over weeks and over months, the stool will be accumulating in the rectum. This will cause dilatation of the rectum, concrete-like material in the rectum, and defecation, of course, will be a very painful experience for the child. So that's why we administer a laxative treatment or lubricant treatment to make this stool very soft, and the child can pass it without pain or discomfort. So if they understand why you are treating them with laxative for a long time, they will buy into it, rather than taking the treatment for 1 week and then stopping, and then the problem happens again. If you want to talk about differential diagnosis of this can take many hours, although the focus of today's lecture is about functional constipation. Although as a pediatrician, primary caregiver, or a pediatric gastroenterologist, you have to emphasize to rule out anatomical abnormalities, anal stenosis, Hirschsprung disease, metabolic like lead poisoning, whether this is a side effect of medications, cystic fibrosis, hypothyroidism, hypercalcemia, celiac disease, food intolerance, like cow's milk protein allergy in small babies, and others like connective tissue disease or certain genetic syndromes related to abnormal abdominal musculature. So your history and physical exam can direct you whether this is a functional problem or this is an organic problem. If you want to take a history, I always take careful history. Like any patient come to you in the clinic, we have to take a careful history about the frequency, consistency of stools, age at onset, what time the stool was passed after birth, is it within 24, 48 hours, it was delayed or not, toilet training experience, was it painful, withholding behavior, we always take description or video how the child is reacting with defecation, if they have pain or bleeding with defecation, abdominal pain, other symptoms like nausea, vomiting, weight loss, perianal disease, because this can be directed to you to Crohn's disease. And believe it or not, we have a lot of children with Crohn's disease come to us with constipation. They don't come with diarrhea because disease don't read books. We have odd presentation of certain diseases. We have children come to us with constipation, overweight, and when we do celiac screening, it is sky high, more than 100. So constipation was a predominant feature of celiac disease in this patient. A previous evaluation and treatment, we have to focus on this. Show me the medication that you are taking, how frequent, what is the form, how do you prepare it, is the child taking this daily or not, and assessment of compliance and adherence to medication, which is very vital. We always instruct our parents to have a diary for stools. They have to put it on the fridge or something visible for them daily, and then they have to record what was the stool frequency, what is the consistency of it, so we can keep track of what's going on with the child. So this is a typical withholding behavior. I always ask the parent when they come to me in the first visit, what is he doing when he wants to pass motion? So this is a very typical appearance, probably most of pediatricians here saw this. The body becomes stiff, they cross their legs, tighten their gluteal muscles, walk on tiptoes, or hold on the furniture, some even squall or hide. Parents often misinterpret the behavior as effort to push. After successful attempts to withhold, the urge to defecate disappear, and the rectum becomes dilated and filled with fecal material. Soiling might happen. Very important to take accurate history, so they try to withhold the stool, not to push it. And you know, most of the parents with experience, they will tell you, yes, he's doing this. In physical exam, we have to take a careful physical exam, focusing on general exam of growth parameter, weight, height, head circumference. Abdominal examination, looking for fecal masses. In neurological exam is very important. Check reflexes, check the back, examination of the perianal area and digital examination, which is mostly not done by our pediatrician. I think it's a vital part of doing a digital rectal exam for all children coming to you with the chronic constipation. You will be surprised to look at the bottom and you can see many findings that can lead you to a lot of things. You know, not all Crohn's patients should be underweight. Not all of them should be having diarrhea with blood or without blood. You will be surprised to see skin tags, fissure, fistula. We have been seeing, you know, miserable children coming to us with a long-standing history of multiple perianal abscesses coming to the emergency department for incision and drainage for 18 months. The child didn't lose weight, didn't have fever, no extraintestinal manifestations, but he had florid Crohn's disease. That was missed for a long time. Something that you don't want to miss as a pediatrician is Hirschsprung disease, which is 1 in 5,000 live births. And basically it happens because of the failure of neurocrest cells to populate in distal colon and permit relaxation, usually present in the neonatal period. However, we have been seeing cases that present with ultra short segment of Hirschsprung disease, older age. They present with constipation that's very severe and refractory to treatment at the age of 5 or 6 years and being operated at that age. And you need a high degree of suspicion to diagnose this. If you have a suspicion, you can perform a barium enema as a screening test looking for transitional zone, and then you can refer to a pediatric surgery to perform a full thickness rectal biopsy looking for ganglion cells under the microscope in order to rule it in or out. Spina bifida is another etiology that you don't want to miss. So the message here is always look at the bottom and look at the back and examine the child neurologically. At least once in the initial visit, you have to do this. Also myelomyangioceal, you look at the back to see if there is any neurological abnormalities, any tuft of hair, any suspicion of spinal cord involvement with this. I encourage all of you to look at the NASPGHAN and SPGHAN joint statement about evaluation and treatment of functional constipation in infants and children. This is evidence-based recommendation. We are moving from expert opinion to evidence-based recommendation. This was published in 2014. It's a very useful document. It's available online and it's free. What kind of investigation? If you have a careful history and physical examination, you don't need to do extensive evaluation in terms of lab investigations. Because as a pediatrician, you are able to tease out whether this is a functional problem or organic etiology. However, sometimes if you have obese child who refuse to be examined, X-ray of the abdomen might be useful to demonstrate fecal loading. Sometimes if you have suspicion about neurological abnormalities, like I mentioned earlier, you can do MRI. Barium enema, if you have a high degree of suspicion for Hirschsprung disease and rectal biopsy, you can check electrolytes and thyroid function test and celiac screening in selected population to rule out these etiologies. Again, this demonstrates only 5% of etiology of chronic constipation in children. 95% of kids have a functional problem. KUB, whether it's useful or not. So several different scoring systems have been used. A retrospective review by many people found poor inter-observer reproducibility, concluded that KUBs of limited value can be helpful to document at least once. We don't repeat X-rays to demonstrate that the child is clean. This is the message I'm trying to emphasize here. But in certain situations where you cannot assess this patient have impaction or not, have significant constipation or not, it might be useful of limited value, but we don't advocate to repeat X-rays to demonstrate the improvement in symptoms. You go by clinical picture. Elements of treatment, which is the main focus of this lecture, is education and demystification, optimizing diet, fiber and fluid. However, I would like to remind you that from evidence-based point of view, they found that children with constipation should follow normal fiber intake and normal physical activity, in addition normal fluid intake. They don't need to take excessive amount of fluid, exercise or fibers. We always talk about it. It's easily said than being done, because the amount of fiber recommended is huge, and if you take a lot of fibers in your diet, it can lead to negative consequences like indigestion, flatus and so on. Behavioral modification also have been advocated with the calendar, which we always tell our parents to do. Is setting a schedule. It's good to tell parents to instruct the child to sit in the toilet at least 10 minutes after meals, at least twice a day in the morning and the evening. and also medical therapy with a good compliance. If you want to remember anything from this lecture, you can remember this table telling you that we have different options of treatment of constipation, starting with lubricant like mineral oil, osmotics like lactulose, sorbitol, magnesium hydroxide, lavage. The drug that we recommend as a pediatric gastroenterologist from evidence-based point of view is polyethylene glycol 3350, Javilax, Merilax, or trade names, with a dose of 0.4 to 1 gram per kg per day in one dose or divided doses. Other stimulant medication, we don't recommend to use them because it has a lot of side effects like abdominal cramps. And if you want, usually we give the parent a choice of having one drug with good compliance and continue on it rather than combining agents, except in severe situations. So the message of this slide that polyethylene glycol is the first line of treatment. If it is not available, sure. If it's not available, you can give lactulose. And the dose of lactulose can range from 1 to 3 ml per kg per day. And this is the problem with underdosing. We have a lot of children referred to us in the clinic with underdosing of lactulose. Don't be afraid. Give the optimum dose, make sure that the child is taking it, and then monitor the compliance. Minimum duration of treatment is 2 months. At least 1 month after that of disappearance of symptoms before considering weaning or stopping the medication. So this is a case with 60-year-old male with 2 years history of what appears to be functional constipation. He has failed many treatments. This is the X-ray of this child, which is demonstrate fecal loading. The idea of this slide is you have to do disimpaction before maintenance treatment. And disimpaction can be done orally or rectally. So disimpaction is very important to evacuate the stools from the colon and rectum, and then you have to put the child on maintenance treatment. There is no difference between rectal and oral disimpaction from studies. You can give high dose of oral polyethylene glycol for 3 days. No need to give enema with that or suppository. Oral does work. This is just example of a diary. This is some options for treatment in the future. This is not being validated in children. The prognosis, so it's a chronic condition. Relapse rate is very high. Prolonged treatment is required at least for 2 months, with 1 month after that with disappearance of constipation before stopping the medication. I always tell my parents and my patients that duration of treatment equal duration of symptoms. So usually it's a prolonged course. Take home message of this: most children with constipation do not have an underlying organic etiology. History and physical exam are usually sufficient to make the diagnosis. Tests are indicated to exclude specific diseases. Treatment of constipation in children is evolving from expert recommendation to evidence-based treatment, and polyethylene glycol-based solution is the mainstay of treatment. Thank you very much.
Thank you very much, Dr. Fawaz, for the lovely presentation, and I think it's everyone got the idea for this chronic problem and the treatment, especially that we know now that it's mainly due to non-organic causes. Now we can take some questions.
Shukran, Dr. Fawaz. Thank you very much. You know, I am working in pediatric gastroenterology outpatient in Jahra. As you said, more than 60% of the cases coming is due to chronic constipation, functional constipation. Only I want to ask about something only called the dyschezia or painful defecation, even the stool is normal. How to manage this condition, Yani?
Okay, so it's a very important question. So Dr. Ghawabi is talking about infantile dyschezia or pain when they pass motion, but when you examine the stool, it's normal, it's not hard. It's a very challenging situation, and if you read the guidelines, we recommend just reassurance with this. You know, we have some entity with children, they might present with hard stools, okay, and dyschezia as well, so we give them laxatives. But you know, we use some behavioral techniques for them, relaxation, reassurance of the parents, and usually dyschezia go away with time. But you don't want to miss something behind the dyschezia, especially in small babies, like cow's milk protein allergy, or constipation, or colic, or something else. So, dyschezia is a diagnosis of exclusion after, ruling out other etiologies. I agree with you, but there is nothing much you can do with dyschezia. You can rule out other diseases, you might give them relief, but you have to make sure that there is nothing behind the dyschezia itself.
In some infants, when they are few months, 2 or 3 months, and they have pain during defecation and soft stools, once you make PR, sometimes it is narrow, it is not stenosis, but they have some membrane, and if you do PR, it will solve the problem.
I don't know about doing PR and relieving problem, but dyschezia is a functional problem, and usually it goes away with time.
Yeah. One question about botulism. If you are seeing cases of botulism here in Kuwait or not?
We don't.
We don't.
Yeah. Okay. Yes.
Thank you, Dr. Fawaz, for the presentation. A common practice we have encountered in our daily practice is that doctors recommend changing formulas for infants who suffer from constipation to either a different brand or a specially designed constipation formula. What is your opinion on this?
Okay, so a very important question, changing formula. I think, I didn't show a slide. One of the red flags for constipation is constipation that starts early in life. So constipation 5, 6 years old is okay. We have to figure it out, functional constipation. I always worry when a baby comes to me with constipation because I have to look for a reason. It's very uncommon, especially babies below 1 month of age having constipation. I'll be really thorough in making sure that this child doesn't have underlying problem. Okay, we know that formula-fed babies are more likely to have constipation. But again, we have to do homework, making sure that you are ruling out cow's milk protein allergy because they are present with constipation, cystic fibrosis, Hesselbank disease, and other things as well. After excluding everything and making sure that this is a functional constipation for a baby, there is some benefit in giving them a formula that has added magnesium, which has a laxative effect, which is the IT formulas that can be used to alleviate the constipation in this age. Not only that, laxatives can be used in small babies because there are studies on lactulose, especially below 6 months, that can be safe and used. However, for children older than 6 months, polyethylene glycol can be used as well. So again, changing formula is okay, but after excluding all organic etiologies, and it should be for a limited period of time. Children during weaning time from formula or breastfeeding to solid or semi-solid, this is a very common area of constipation as well. So you have to take all information. I always like to give them non-pharmacological option at the beginning, so you can try, certain chamomile, certain, maybe in older age you can prune juice and stuff like that to alleviate this problem rather than sticking them on medication right away.
Dr. Fawaz, how do you manage a child with this withholding behavior?
Okay, so question about withholding behavior. So this child is withholding because he doesn't want to defecate and because the stool are hard and accumulated in the colon and rectum. So the treatment of this has 2 parts. You have to do a lot of behavioral modification, a lot of sitting toilet strategies, and you have to give them aggressive treatment with laxative as well. Once you make the stools soft and nice, the child can pass it without pain and discomfort. And this will take not a day or 2. It will take a long time. And the family have to buy into this as well. Most of families, I always tell them, I'm not with you at home, so I don't know what are you doing. And they are, burned out after a week or 2 of doing this. It's always challenging to treat functional problems in children. It's much easier to treat a pneumonia or otitis media and other things. But these problems like functional constipation, colic, and so on, it takes a lot of time from family and from practitioners as well. Yes. Yes. So you wean him over a few months. That's 2 to 3 months. I usually, what I do, I cut so the question just for the audience to hear it, the duration of treatment I mentioned is 2 months with 1 month additional, so 3 months at least. If the child has a constipation of 1 year, yes, I will treat him for a long time, at least 6 to 12 months. If I'm making sure that the child is compliant, is very good with the treatment, I usually wean them slowly by 50% for 1 to 2 months, and then I can stop it. Or sometimes for children who are resistant, the weaning will be much slower by 25% every month. till we stop it. Some, parents do this voluntarily by themselves. They give the drug every other day or so till the child is stopping, because we look from practice and from studies that if you stop the medication abruptly, the relapse rate is very high. The same problem with the proton pump inhibitors, Losic, omeprazole, other drugs. Another message for my colleague pediatrician: don't stop the drug abruptly, because there is a phenomena of rebound hypersecretion with a proton pump inhibitor. Once you stop the medication, even in healthy children who are giving a proton pump inhibitor, you create symptoms. My advice: always wean a proton pump inhibitor before stopping them. Don't stop it abruptly. Yeah. Yes. So a question about lactulose. Yeah, lactulose is synthetic disaccharide, fructose and galactose, is not absorbed by the gut and create a lot of gas. I prefer, personally, I don't use a lot of lactulose. I use polyethylene glycol because it doesn't have this side effect and given once a day rather than lactulose, which should be used twice or 3 times a day. But again, some children doesn't like the salty solution of polyethylene glycol, and they like lactulose because it's sugary. So my first choice is Movicol, and my second choice will be lactulose. Lactulose for small babies.
Thank you very much, Dr. Fawaz. And we're going to move for the second